Hi everyone, I hope I'm audible as well as my screen is visible. So we would be waiting for 5 more minutes so that everyone could join and then we'll begin this lecture. Hi Harshita, so how are you guys doing? Okay, so let us begin the session. So all of you who are new here, myself Dr. Simran Kaur, I'm a radiology resident and I teach students for USMLE also. And in this lecture we would be talking about the basics. So this is the point where maximum students they get stuck because yes, it's very difficult to understand the basics and it's easier to do the rote learning. And we know the system of our med schools, what we do, we pass the exams, we learn things, and eventually we don't even understand the meaning of a lot of things, and we miss on the things that are very essential for the entrance examinations. So when you talk about the medical entrance examinations, so we have NEET, NEXT, or INICET, and we have international exams like USMLE. Okay, so no, there are a lot of debates regarding NEXT and NEET and INICET, though they are already taking place. So these days, what's changing is the trend. Okay, so all these exams are now following the trend of USMLE. So USMLE is the United States Medical Licensing Exam, and not just for the sake of preparing for this exam. Even if you want to understand a lot of basic things, and if you want to clarify your concepts and make your base very strong for Indian entrance exams also, you should definitely prepare in a way the way that USMLE has to be dealt with. So the way is, follow the clinical scenarios. Okay, so you have to go through the clinical vignettes. You just imagine the patient sitting in front of you in your OPD and a lot of things regarding the clinical scenarios, not just the one-liners or not just for the sake of just, getting done with the exam. So, what's the purpose of the discussion in the first part of this lecture is how you can efficiently prepare for both the exams. Now, the main important thing here is that if you prepare for USMLE, definitely you're gonna do good for the Indian entrance examinations because these days, if you have seen the changing trends, the questions are in the clinical format, so it's very easier for us. If you supposing the gold standard, the question bank for USMLE is UWord. So if you solve questions of that question bank, you will see that a lot of clinical scenarios are given, and then you are expected to think about those scenarios, and ultimately while you imagine yourself being there in that clinical scenario, you will be given the lab values as well as the clinical symptoms. So you will eventually learn a lot of things that would be very important practically also. Now when you talk about the NEET next INI-CT, okay, so these exams, as you know, they are following the clinical pattern. So these two exams, NEET next or INI-CT along with the USMLE, they should be prepared together. Okay. So I always suggest everyone to read First Aid for USMLE, even if you're not preparing for USMLE at all, because that book is an ocean of knowledge. It is having really good concepts and precise to the point information. So even if you want to go ahead with the next INI-CT or NEET, First Aid is going to be your Bible. Okay, and simultaneously you can prepare for USMLE also. So that is the advantage there. Now moving on, so let's talk about clearing the basics. Okay, so when you talk about the basics, for example, let's talk about the cardiac physiology. So these are the topics that we are always scared of because they seem to be very alien or they seem to be very complex. But if you talk about how our heart works basically, what things you need to know. So let us talk about that first of all. So let us try to understand the basics about how our heart works. So how you have to imagine. So when you start cardiovascular system, how you can have an imaginative memory about heart. Okay, so this diagram is going to help you in understanding a lot of pathophysiologies regarding the different diseases also. So let us try to understand what's happening here. So this chamber is known as right atrium. This is right ventricle. This is left atrium. This is left ventricle. All right. Now we have a valve between right atrium and right ventricle. Which valve is that? Which valve is present between the right atrium and the right ventricle? So simultaneously, you guys can, try to answer the questions. Yes, who can answer this? Which valve is present between right atrium and right ventricle, and hence known as the right-sided valve? Exactly. So we have a valve known as tricuspid valve. Tricuspid valve. Okay, and tricuspid valve is known as the right-sided valve, as it is present on the right side between the right atrium and the right ventricle. Similarly, between the left atrium and the left ventricle, we have a valve. Which valve is that? Between the left atrium and the left ventricle, we have which valve? The answer is mitral valve. So we have mitral valve between the left atrium and the left ventricle. Now, from where does the blood come into the right atrium? Someone has to bring the blood to the right atrium so that the blood should be pushed from the right atrium to the right ventricle and hence into the furthermore circulation. Okay, so IVC, that is inferior vena cava, as well as SVC. They pour the blood into the right atrium. All right. Now, at the roof of the right atrium, where the SVC is entering into the right atrium and pouring the blood, we have a very specialized structure over there. Can anyone tell what is that? So we have a very specialized structure at the roof of the right atrium. What is that called? What is the answer to this question? Yes. So what we have is SA node. Exactly, Rohit, you gave the right answer. We have SA node. So don't, ever get confused between different things. So SA node, we keep on talking about it, right? So this is the part of the conducting system of the heart. But where is this SA node present? This SA node is present at the roof of the right atrium where SVC is, pouring the blood into the right atrium. Moving on, once the blood enters the right atrium, this has to go into the right ventricle. And, what is allowing this blood to reach the right ventricle is the tricuspid valve when it opens. So when right atrium is contracting and ultimately the blood is entering into the right ventricle via the tricuspid valve. Now, via the right tricuspid valve, once the blood has reached the right ventricle, from the right ventricle, where is this blood going? Where is this blood going from the right ventricle? Anyone? So remember this thing, that from the right ventricle, the blood is going to enter the pulmonary artery. The blood is going to enter the pulmonary artery from the right ventricle. All right. And there is a valve present here. Which valve is present here? This is known as pulmonic valve. All right. Now from the pulmonary artery, the blood enters which structure? From the pulmonary artery, the blood is going to go to which structure? The answer to this question is heart. Sorry, the lungs. Okay, I'm really sorry. From the pulmonary artery, the blood is going to enter into the lungs, right? In the lungs, there is going to be oxygenation of the blood. And from the lungs, now the blood is going to move towards the left atrium. So from the lungs, the blood is being carried to the left atrium with the help of pulmonary veins. So pulmonary veins are helping in that, in carrying the blood from the lungs into the left atrium. Now, once the blood reaches the left atrium, the blood has to go into the left ventricle, and this is made possible with the help of mitral valve when it opens. Once the blood reaches the left ventricle, where do you think is the next destination of this blood? Where do you think is the next destination of this blood? This blood from the left ventricle is now going to enter into the aorta. So we have aorta. The blood from the left ventricle is going to enter the aorta. All right. And from the aorta, via different branches, it is going to reach the systemic circulation. So throughout the body, the blood is going to be distributed. Systemic circulation. And we have a valve present here also. And the valve that is present here is known as the aortic valve. This is known as the aortic valve. All right. So I hope this basic diagram of heart and how the blood is flowing through this heart is clear to you. All right. Now, next question: what type of blood is there in the right side of the heart? What type of blood is there in the right atrium and right ventricle? Anyone? So remember, we have deoxygenated blood. Okay. So deoxygenated blood present on the right side. But once the blood is exiting the lungs and this blood is entering into the left atrium, the left-sided heart is going to have oxygenated blood. And this oxygenated blood is furthermore distributed throughout the body via the aorta. All right. So this is the basic functioning of the heart. Please know this. Moving on, supposing the patient is having hypertension. The patient is having chronic, long-standing hypertension, and the patient is also not compliant with the medications. The patient is not taking the medications regularly, right? So what could be happening as a result of it? Anyone? So let's try to understand that phenomenon also. So I'll draw this picture again. I'm going a little bit slow because I just wanted to explain you the basic physiology of heart. Few principles. Okay, so this is right atrium, right ventricle, left atrium, left ventricle. And here you know that there is aortic valve, and then the blood from the left ventricle is going into the aorta. Now, if supposing the patient is having long-standing hypertension and the patient is also not compliant on the medications, so what is going to happen is total peripheral resistance is going to increase. So pressure inside the aorta is going to be very high. So blood pressure is the pressure exerted by the column of the blood on the wall of the vessel. Okay, so BP is high, so pressure in the aorta is high. Now what is happening if this continues for long? Left ventricle will have to force the blood into the aorta with much higher strength or force, okay, as compared to the normal situation. So left ventricle has to apply a lot of force in order to, force this blood into the aorta. And if this continues for long, there is going to be a change, adaptive change, that is left ventricular hypertrophy. So that is how whenever you talk about a chronic long-standing hypertension case, so you always suspect left ventricular hypertrophy. This is the reason why, because left ventricle has to exert a lot of force in order to, pump the blood into the aorta, because the pressure, the resistance in the aorta is very high. Moving on. Now let us try to understand few basic terms in terms of cardiac physiology. So we have heart rate, we have cardiac output, stroke volume, and ejection fraction. Okay. So when you talk about the heart rate is like number of contractions the heart is beating per minute, right? So number of contractions of the heart per minute, that is heart rate. And the normal heart rate is 60 to 100, you know this. What is cardiac output and stroke volume? So they are quite similar to each other. So the main differentiating point between both of these, so the amount of blood that is pumped by the ventricle, left ventricle, for example, per minute. So what you have to highlight is that how much blood is being pumped by the heart per minute, that is going to be cardiac output. But how much blood is pumped by the heart in one single heartbeat, that is going to be the stroke volume. All right, so this is the difference between both of them. And moreover, cardiac output, we have a formula. So even if you are given few values, you can easily calculate the cardiac output. And how you can do so? Cardiac output is equal to heart rate into the stroke volume. All right, so if you are given stroke volume and heart rate, you can definitely come across this cardiac output. When you talk about stroke volume, amount of blood pumped by the heart per heartbeat, and we have a formula for stroke volume also. End diastolic volume minus end systolic volume. Okay, so end diastolic. So let us try to understand this in a simpler way. End diastolic volume. So what do you understand by end diastolic volume? What is this end diastolic volume we are talking about? So remember, diastole means a relaxing phase. Okay, end means at the end. So at the end of the, the diastole, the relaxing phase of the ventricle, right? How much amount of blood is remaining in that ventricle? This is known as the end diastolic volume. But when you talk about the end systolic volume, so at the end of the systole, that means systole is related to contraction. So at the end of the contraction, how much amount of blood is remaining in this ventricle? That is end systolic volume. Remember this. So the stroke volume is equal to EDV minus ESV. Now you might have come across this term ejection fraction. So a lot of times, supposing the patient is coming to you with chest pain or any cardiac complaint, so you usually get the echocardiography done. So there's an investigation known as echocardiography. By doing echocardiography, you can look at the anatomy of the heart, as well as you can look at the function, the physiological functioning of the heart. Is the pumping proper or not? Okay, and if there is any anatomical defect in the heart, so that also you can get to know by doing echocardiography. So this is the echocardiography. Now, how you can come across this ejection fraction? Your answer is by doing an echo. So by doing an echo, you can get the ejection fraction. What is ejection fraction? That how much proportion of this end diastolic volume is ejected by the ventricle. Okay, so we have certain amount of blood in the ventricle after the diastole. That is known as the end diastolic volume. Now, how much of that end diastolic volume, the amount of blood that is there in the ventricle, is being ejected by the ventricle, that is known as the ejection fraction. Okay, so how much fraction of blood actually is being ejected by the ventricles? So in simple words, this is ejection fraction. The normal ejection fraction is 50 to 70%. 50 to 70%. Okay, so usually supposing you see ejection fraction around 40 or 45, so these patients, they have low ejection fraction and they are going into heart failure. So remember this concept regarding ejection fraction and echocardiography. All right. So one integrated concept here, very common. So supposing this patient is a female having breast cancer. A female having breast cancer, she has to be started on drug X, which is known to be cardiotoxic. First of all, which drug we are talking about? Breast cancer patient has to be started on a drug which is known to be a cardiotoxic drug. Yes, Virender, the answer is Trastuzumab. So we are talking about Trastuzumab. Okay. Now, Trastuzumab is known to be a cardiotoxic drug because it leads to cardiomyopathy. Now imagine if you start Trastuzumab in a patient who is already having a pre-existing cardiac condition. So you're gonna end up this patient in heart failure. So What is the prerequisite before starting trastuzumab in any patient of breast cancer? What should be done before starting it? What should be done before starting it? The answer to this question is echocardiography. So do an echo, look at the ejection fraction, look at the functioning of the heart, look at any structural defect in the heart. Okay, so if there is any defect in the while you do the echocardiography, so definitely you're not gonna start trastuzumab because this is a known cardiotoxic drug. This leads to cardiomyopathy. All right. So echocardiography is very important before starting the trastuzumab. All right. Moving on. Now let us understand about the conduction system of the heart. So how the impulses, now there is initiation of the heartbeat, how there is impulse conduction in the heart, how the atria and the ventricles, they are able to have a synchronized kind of conduction and contraction. All right. So how the contraction of the heart muscle are so coordinated, this is what we are trying to understand. So we have specialized structures, and they are SA node, AV node, bundle of His, Purkinje fibers. So let us try to understand their role in the conductivity. So when you talk about SA node, I already told you where it is present. It is present at the roof of the right atrium, where the SVC is pouring the blood into the right atrium. Now, SA node is going to simultaneously, it is going to spontaneously, in fact, generate the electrical impulses. So this is a very important structure, and this is known as the pacemaker of the heart. So it is going to generate the electrical impulses. From the SA node, the impulses are going to travel into the AV node. Okay, so impulses are going to reach into the AV node. Now, very important function of AV node. So once the SA node has started the electrical impulse, ultimately what is going to happen, there is going to be a contraction of the atria. There is going to be contraction of the atria. But after that, this impulse is reaching the AV node. Now what should happen is there should be contraction of the ventricles. But there is something that is happening in between. So AV node is performing a very important function of a delay in the conduction. It is having a slow conduction. What is the reason for the slow conduction of the AV node? There's a reason why the conduction in the AV node is slow. The reason is that if AV node is passing the electrical impulse in the same speed as the SA node, the atria and the ventricles are going to contract at the same time. The ventricles are not going to get enough time to fill themselves with blood. This is the reason why there is a delay in conduction via AV node. Okay. So what happens is that there is delay. This is what I have written. So this helps in delaying the conduction so that the ventricles could get some time to fill with blood. So this delay by the AV node is very important. This is having slow conduction velocity. After the AV node, the impulses are going to reach to a structure known as bundle of His. And bundle of His divides into two, right and the left bundle branches. Okay, so I'll draw a picture here. So supposing this is interventricular septum. Supposing this is right atrium, this is left atrium. So we have right ventricle and left ventricle. This is interventricular septum. Okay, so what's going to happen is bundle of His will divide into two branches, left and right bundle branches. Left and right bundle branches. Alright, so the impulse is going to travel in this way, and ultimately these are going to terminate into the terminal branches known as the Purkinje fibers. Into the Purkinje fibers. So what's going to happen? From the bundle of His, the impulse is going to reach into the Purkinje fibers, and ultimately the ventricles are now going to contract. The ventricles are now going to contract. Alright, so these are the specialized structures that help in the coordination of the, the contractions of the heart muscle. So how this impulse conduction is taking place, from the SA node, the impulses are going to reach into the AV node, from the AV node into the bundle of His, from the bundle of His into the Purkinje fibers ultimately. So Purkinje fibers, they are having the fastest cardiac action potential conduction. All right. Moving on. Now, this was about few of the concepts regarding cardio. And now let us try on some hematology concepts. So hematology also, this is very, heavily tested on ini-cet. And this is important also. So supposing you come across this scenario, so look at this cue card. So these are the keywords. So supposing you get a patient of road traffic accident, the patient comes to the casualty and there is a fracture of tibia, okay, or any of the long bone. Now, what should be happening to the reticulocyte count here? So can anyone talk about it? So what is the concept that we are talking about and what should be happening to the reticulocyte count? Now, in order to basically understand this question, you should first of all know what are the reticulocytes. You might be knowing this. Reticulocytes are immature RBCs. Reticulocytes are immature RBCs. Okay, so there is erythropoiesis. Erythropoiesis means the process of formation of the RBCs. And erythropoiesis is taking place in the bone marrow. And one of the precursor of RBCs, that is reticulocytes. The reticulocytes are formed in the bone marrow and they are released into the circulation. So reticulocytes come into the circulation and they remain in the circulation for approximately 24 hours. And ultimately they convert into the mature RBCs. And ultimately mature RBCs are being formed. Now what happens is, whenever there is hemorrhage or blood loss due to any reason. So most commonly you talk about the road traffic accident, the patient has lost a lot of blood, or there is long bone fracture, or whenever there is hemolysis. Whenever there is hemolysis. Hemolysis means excessive breakdown of RBCs. Excessive breakdown of RBCs. Okay. So these are the two situations, guys. Please remember these two situations. These are the situations in which there is going to be compensatory increase in the reticulocytes. Increase in the reticulocytes. Now, what is the reason why reticulocytes are increasing here? The reason is that when the patient is having blood loss, so yes, the body needs compensation. The body needs to make more RBCs, right? So erythropoiesis is taking place there. When hemolysis is there, when the RBCs are getting excessively broken down, in that situation also you need more RBCs. So the precursor of the RBC, that is reticulocyte, that is going to be increased. So this is a compensatory change. And remember these two situations, blood loss as well as the hemolysis, these two situations, the reticulocyte count is going to increase. All right, very important. Now look at the question again. Patient of road traffic accident, fracture of long bone is found. What should be done? What should be, happening to the retic count? What should happen to the reticulocyte count in this situation? Increase or decrease? What do you think? Increase or decrease? Anyone? Yes, Virender. Srija, you give the right answer. So this should increase because I told you two scenarios, hemolysis and the blood loss, where retic count is going to increase. So your answer to this question is going to be increase in reticulocyte count. Moving on. So look at the clinical scenario. Pregnant female coming to the OPD, you get the lab testing done. She's having pallor actually, so you get the lab testing done. The serum iron levels are less, ferritin is less, hemoglobin is less, MCV is less, and she's having irresistible urge to move her legs. She says that doctor, whenever I lie down, especially before sleeping, and throughout the day also, she's having urges to move her legs. So what is the situation that we are talking about? Anyone? So what is the situation that we are talking about here? So can anyone talk about it? So just imagine, look at the lab panel here. First of all, the keyword is that the female is pregnant. The female is pregnant. Okay. Second thing, iron is less, ferritin is less, hemoglobin is less, MCV is less. Okay. Now serum iron is less. Okay, got it. But what is ferritin? Ferritin is the storage form of iron, and that is also reduced here. Hemoglobin is also reduced. MCV is also reduced. So this is a state of iron deficiency anemia in a pregnant female. MCV is corresponding to the size of RBCs. So MCV less than 80 femtoliter. This means the cells are going to be microcytic. So the iron deficiency anemia is microcytic hypochromic. MCH is also less. Alright, so pregnant female having iron deficiency anemia, urge to move the legs. The answer to this question, as someone rightly said, Virendra, you gave the right answer. This is restless leg syndrome. Okay? Restless leg syndrome. So what's the take-home message regarding it? The take-home message is that restless leg syndrome is the irresistible urge to move the legs. Okay? Now, this is very commonly associated with pregnancy as well as iron deficiency. So if you remember these two keywords, pregnancy and iron deficiency associated with restless leg syndrome. Okay? So this is the whole scenario that describes the restless leg syndrome. Moving on. Okay, so I was talking about MCV, mean corpuscular volume. So MCV, when you talk about it, so anemias are usually being divided on the basis of MCVs. So MCV, it is normal when it is 80 to 100. When it is less than 80, it is going to be less, more than 100. That is increased MCV. Okay. So 80 to 100, this is normocytic anemia. Less than 80, microcytic anemia. More than 100, macrocytic anemia. Okay. So this is how you usually divide the anemias based on MCV. Normal MCV is 80 to 100. And iron deficiency anemia shows microcytic hypochromic type of anemia. Okay. Moving on to the next scenario. So look at the picture and try to answer this question. So what are we talking about here? Young female, hemoglobin 10, and peripheral blood smear is given. You will see this kind of picture. MCV is less than 80. So what is it? Anyone? So what is the answer here? Yes. So what is shown in this picture first of all? So someone said B12 deficiency. Why do you think B12 deficiency? B12 deficiency, first of all, MCV would be more than 100, especially more than 110. And secondly, in B12 deficiency, you will see hypersegmented neutrophils. The cells will be large, macrocytes will be there, right? Here, what we are seeing is target cells. So we are talking here about thalassemia. So we are talking about thalassemia. All right, moving on. So look at the clinical scenario here. Young female, reduced hemoglobin, reduced iron, ferritin increased, patient on ATT. So ATT is anti-tubercular treatment. What are the first line drugs for TB? HRZE. Isoniazid, rifampicin, pyrazinamide, and ethambutol. Okay. Quickly integrating this here. Isoniazid, a lot of side effects. For example, it depletes B6, so the patient could have peripheral neuropathy. Along with that, B6 acts as a cofactor for the conversion of tryptophan to niacin, which is vitamin B3. So if B6 is not there, niacin is not going to be formed, so the Patient who's on isoniazid could also develop pellagra-like symptoms. Pellagra-like symptoms. And third thing about isoniazid is it is hepatotoxic. It is a hepatotoxic drug. Another thing, isoniazid inhibits the mycolic acid synthesis. Mycolic acid synthesis, and mycolic acid is the part of the cell wall of mycobacteria. Rifampicin, orangish discoloration of the body fluids. Right? To some extent, it is also hepatotoxic, and it is an enzyme inducer. Pyrazinamide increases the uric acid levels, so increased risk of gout. Ethambutol leading to optic neuropathy, red-green color blindness. So these should be on your tips. These are the keywords. These are the side effects of the anti-TB drugs. Red-green color blindness. And ethambutol works by inhibiting the arabinosyl transferase. Arabinosyl transferase. This is the enzyme that is being inhibited by ethambutol. Alright. Now moving on. So what we were seeing in this scenario was that hemoglobin is less, iron is less, ferritin is more. If it would have been the iron deficiency anemia, what should have happened to the ferritin? Yes. If this would have been the iron deficiency anemia, what could have been happening to ferritin levels? If this would have been iron deficiency anemia, ferritin should have decreased. But here what you are seeing, ferritin is increasing, right? And along with that, the patient is having tuberculosis, which is a chronic infective disease. Tuberculosis is a chronic infective disease. So it is clear that the patient is having anemia because hemoglobin levels are less. And it's also clear that the patient is having chronic infective disease. So what we are talking about here, we are talking about anemia of chronic disease. Rohit gave the right answer. The answer to this question is anemia of chronic disease. Anemia of chronic disease. So guys, anemia of chronic disease is a type of anemia which happens in the patients who are having chronic inflammatory or chronic infective conditions. Alright. Now, when you talk about anemia of chronic disease, the levels of ferritin, they are increasing. What is the reason for that? Why ferritin levels are increasing in anemia of chronic disease? Although iron is less. The reason here is that although iron is less, but what you should also remember is that ferritin is an acute phase reactant. Ferritin is an acute phase reactant. Especially, this is a positive acute phase reactant. So we have negative acute phase reactants also. For example, we have transferrin and albumin. So ferritin is a kind of positive acute phase reactant. That means whenever there is increasing inflammation or there is going to be infection in the body, the ferritin levels are going to increase. So hence this patient who is having chronic infective disease, ferritin should be increasing in such case. Alright, so this is the reason why ferritin levels are increasing in anemia of chronic disease despite of decreasing levels of iron. And this is a very, very strong differential of iron deficiency anemia. Alright, moving on. So guys, apart from tuberculosis, you could be given, any kind of chronic inflammatory condition. For example, you could also be given rheumatoid arthritis, which is a chronic inflammatory arthritis, which is autoimmune in origin, and other kind of chronic inflammatory conditions too. So you should be having a good, knowledge about the background, that what is happening to the ferritin, why it's increasing, and along with that, one more concept here. Yes, so one more concept here. Am I audible? So someone messaged that I'm not audible. Are you guys able to hear me? Are you guys able to hear me? Okay. Now, whenever there is inflammation, there is also going to be increase in something known as hepcidin. What is hepcidin? Hepcidin is also a positive acute phase reactant. Hepcidin is also a positive acute phase reactant. Alright, so What is the action of hepcidin? If hepcidin is increased, you should know that hepcidin inhibits the absorption of iron. It inhibits the absorption of iron. This is the reason why chronic inflammation or chronic infection, when hepcidin is increasing, absorption of iron decreases. So that is the reason why iron levels are reduced in ACD. Iron levels are reduced. Alright. So hepcidin increase, ferritin increase, both of them are positive acute phase reactants, and serum iron is reduced, and hemoglobin obviously is reduced. So that is anemia of chronic disease. Moving on to the next scenario. Young reproductive age group female having less hemoglobin, less iron, less MCV, less ferritin, urge to eat the ice and the soaps. So what are we talking about here? Anyone? So what are we talking about here? So we are talking about iron deficiency anemia. Okay? Iron deficiency anemia. Why iron deficiency anemia? Number one, hemoglobin is less, so anemia. Second, MCV is less, so it's microcytic. Third, iron is less, iron deficiency. Ferritin is also less, which is the storage form of iron. But what is this last line written here? What is this last line written in the question? Urge to eat the ice and soaps. So we usually don't eat ice or soaps, okay? So this is the urge to eat a non-edible substance, and this is known as pica. Alright, so pica is also common during pregnancy, and pica is very important hint for iron deficiency anemia also. Alright, so this is pica. The urge to eat the non-edible or non-nutritious substances, for example, soaps, chalks, ice, it could be mud also, right? Alright, now look at this scenario. We have elderly male having pallor, that is paleness, okay? So this patient is also having shortness of breath, when hemoglobin levels are 8 gram per deciliter. So guys, is it common for the males to have anemia? Is it common for the males to have anemia? Anyone? Do you think males commonly have anemia? Or do you think females would be having anemia more commonly? What do you think? Yes? Males usually don't have anemia commonly. But if you see anemia in a male, you should think about something pathological. See, females, they have monthly menstrual loss of blood. So this is the reason why the females are more commonly have anemia. All right, and during the birthing process also the blood is lost and the monthly menstrual losses. So females are more commonly having anemia. But if a male is having anemia, you should think about something pathological first of all, right? Now, this elderly male having pallor, shortness of breath, and reduced hemoglobin. So, you should always think about something hidden. So, occult GI bleeding, you should always think about it in such cases. Okay, so occult GI bleeding, occult means hidden. So, if there is any kind of hidden GI bleeding, you should think about that. Now, what is the main differential diagnosis of occult GI bleeding? So either it could be the diverticular bleed, okay? For example, the patient is having Crohn disease, IBD is there, so there could be diverticular bleed, or the patient is having colorectal cancer, or the patient may have angiodysplasia, all right? Or the patient may also have bleeding peptic ulcer. So these are the situations where you may expect the occult GI bleeding, and this is the reason why this male is having anemia, all right? So always look at three situations which are very important if you see anemia in any male, especially the elderly patient. All right. Moving on. So look here. Child sitting in class, teacher is asking questions, the child suddenly starts to stare at the teacher. Child is not responding to either verbal or tactile stimulation, and it is happening for a few seconds, and the teacher, complains that the child is not attentive in the class. She feels that the child is not interested in studying, or she feels that the child is not paying attention. What is this typical history about? You might have heard about it. What is this typical history about? Exactly. So this is absence seizure. Okay, so we are talking about the absence seizures. Now, this happens usually in children less than 10 years, and this, the episode lasts for around 10 to 20 seconds. And the patients who are having absence seizures, they're not responding to either verbal or tactile stimulation. And usually, how the parents get to know, the teacher complains that the child is not attentive in the class. The teacher is actually not knowing that the child is having absence seizure. All right. And what is the drug of choice for absence seizure? What is the drug of choice in this situation? What will be the answer here? The answer to this question is ethosuximide. So ethosuximide is the drug of choice for absence seizures. All right. You can give valproate also if ethosuximide is not working. If it is not working. Moving on. Look at this. So we have an 80-year-old male who is unable to hold urine. The urine leaking history is present. And the patient is also not able to walk properly, is unable to coordinate the voluntary movements. There is memory loss, cognitive impairment is there. And when you get the CT scan done, you have this neuroimaging. What are we talking about here? Yes, the whole scenario is given. At least guess what is given here. Okay, so look here. What are you seeing on CT? Yes. What is given here? This is ventriculomegaly. Ventricles are enlarged. Ventriculomegaly. Yes, someone said hydrocephalus. Okay. But what is this diagnosis? What is this diagnosis? Look at the clinical scenario, look at the history. What are we talking about? Anyone? The answer to this question is normal pressure hydrocephalus, NPH. Normal pressure hydrocephalus. Okay, the triad that is very important: elderly male having ataxia, urinary incontinence, and cognitive impairment. And on CT scan, you see ventriculomegaly. So this is normal pressure hydrocephalus. This is very typical history of NPH. I hope this is clear. You can read about it. Okay. All right. So we are done with today's session. The very purpose of this session was, to make things easy to understand. So whenever you are reading, make flashcards in such a way that you are only writing the keywords. No need to add any notes or something. And try to test yourself repeatedly. So the spaced repetition method of studying should always be followed. All right. I'll see you in the next lecture. I hope you liked it. Bye bye.